Hello, good evening or good afternoon, wherever you are. Welcome to Study Medic's Last Minute Revision Series. My name is Dr. Aparna Vinod. I'm one of the mentors in Study Medic, and today we will be dealing with endocrinology and renal medicine. So, as you all know, endocrinology and renal together will constitute around 38 questions out of the total 200 questions of the exam. So, I hope you're ready for this. So before we start, we are going to give you a roadmap as to what will be covered and discussed in this revision series. Under endocrinology, we will be covering thyroid, diabetes and emergencies, adrenal, pituitary, calcium and sodium abnormalities. Under renal medicine, we will be looking at AKI, CKD, glomerular disease, electrolyte imbalances, and few questions on dialysis as well. Starting with endocrinology and diabetes, this will constitute questions from endocrinology will be around 19 out of the total 200 marks, 200 questions. So before we get into the content, there is always an approach on how you're going to see the questions and how you will arrive at the answers. A few tips on how you should approach the questions in endocrinology. Never interpret the single hormone. It is always an axis. So even if you find abnormalities in a single hormone, try to look for abnormalities in the axis as well. And pair the target hormone with its tropic hormone. We have many abnormalities based on various combinations of low T3 or high T3, T4 with TSH, or try to correlate cortisol with ACTH and such. So in order to have an easy way to remember is to remember high tropic and low target will be seen in primary gland failure. That means the pituitary is working well, but the target hormone is not working well or not producing enough hormone. That will be seen in primary gland failure. Whereas when the tropic hormones are low, along with a low target hormone, it is always a secondary cause. That means the pituitary itself is not working well. We have dynamic tests. So often we have conditions in which the hormones are in excess or when the hormones are deficient. Always remember, we use suppression test for excess, like in Cushing's disease or syndrome, we try to do dexamethasone suppression test. Or in case if the hormones are deficient, like in adrenal insufficiency, we try to stimulate the gland to produce more, which is known as stimulation test or synactin test. And we can also see questions on emergencies, like diabetic ketoacidosis, HHS, adrenal crisis, myxedema, coma, thyroid storm, severe hyper or hyponatremia, hyperkalemia, all that can be seen as well. Now, always remember, sodium, though it is a salt, it is an endocrine problem as well. So we need to always assess the volume status before labeling the cause. That will significantly alter the treatment and management approach. Coming to thyroid disease. So you all know we have hypothyroidism, hyperthyroidism, we have sick euthyroid syndromes and such. So examples of hyperthyroidism will be Graves' disease. So in Graves' disease, a question will involve signs and symptoms of diffuse goiter, eye signs, positive TRUB, toxic nodule, thyroiditis. All this will have a typical history. Like in thyroiditis, the gland will be painful and it be just 1 or 2 days history accompanied by other symptoms. So the treatment for hyperthyroidism can be different at different stages. Mostly it is carbimazole. So when carbimazole is being given to a patient, agranulocytosis warning should be given, pregnancy warning should be given, sick days warning should be given. Or it could be propylthiouracil as well, depending on whether the woman is in breastfeeding stage or pregnancy stage. Beta blocker is always given for control of symptoms. You could also look at other treatment options for hyperthyroidism like radioiodine or surgery, but that will depend on what the patient wants and what stage of the disease she is in or he is in. Then we have hypothyroidism. Very commonly known symptoms, the patient will be presenting with fatigue, weight gain, intolerance to cold, and we usually treat the patient with levothyroxine. And we monitor the patient after the initial starting or initiation of treatment. We will check at 6 to 8 weeks and thereafter at regular intervals of 3 to 6 months. Then there is a sick euthyroid syndrome. So When we do a complete blood panel during an acute illness in an inpatient, we sometimes find this. It is when you have a low T3, T4, and we would expect the TSH to be high in such instances, is it not? But then you will find the TSH will be either normal or low. So that is quite common, and it is known as a sick euthyroid syndrome. So because it has been brought about by the acute illness, you do not need to treat it. So normally what we do is we repeat the thyroid function test in 6 weeks time and decide whether the patient will need treatment or not. So immediately we do not treat the disease. And in pregnancy, always remember, never radioiodine. So even if the patient is living in a house where there could be people in childbearing age, we try to give warning. So it is never radioiodine. And proper thiouracil will be given in the first trimester, and she will be changed into carbamazole in the second trimester. Now, this is a pictograph to help you remember thyroid function versus free T4. As you can see in the x-axis, it is a TSH, in the y it is T4. So in the red box, you have a primary hyperthyroidism. So primary hyper means it involves a gland, the thyroid gland, which is producing excess of thyroid. And when it is so, the pituitary will try to do a negative feedback. So then the TSH will decrease. So low TSH with a high T4 is seen in hyperthyroidism, primary hyperthyroidism, and it is, the example is Graves' disease. When you have a secondary hypothyroidism, it will be low TSH and low T4. So the gland is not producing enough thyroid hormone, and the pituitary fails to increase or stimulate the gland to produce more thyroid. So that is secondary hypothyroidism. Okay, that is, the pituitary will be affected. Now you have primary hypothyroidism in the blue box, in which it says we have low thyroid hormones. So since it is primary hypothyroidism, gland fails to produce enough thyroid hormones, and the pituitary is trying to stimulate the gland to produce more. So you'll have a high TSH with low T4. Okay, and when the TSH will be high and the T4 will be high as well, it is thyroid hormone resistance. Usually you can see in tumors producing TSH. This is a pictograph, again a table trying to differentiate between hyperthyroidism and hypothyroidism. The symptoms are very well familiar to all of us. So in hyperthyroidism, it is increased metabolism. So you will have increased weight loss, you will have fine tremor, there will be heat intolerance, period abnormalities will be there as well, whereas in hypothyroidism, decreased metabolic activity. So there will be weight gain, there will be fatigue, and the patient will tell symptoms of cold intolerance. Now, signs. In hyperthyroidism, if you are thinking about Graves' disease, you will have lid lag, atrial fibrillation, goiter. All such things will be present in Graves' disease, whereas in hypothyroidism, you will have bradycardia, and the patient will complain of dry skin, and when you test the tendon reflexes, it will be slow. If you look at the bloods accordingly, like we said in the last slide, in hyperthyroidism, TSH will be low and high T4 will be present. When we see that there is high T4 in the blood, we usually check for antibodies as well, and you will find TRAb antibodies increased in Graves' disease. In hypothyroidism, anti-TPO antibodies will be present. Hypothyroidism means low thyroid hormone and high TSH. So this is a practice question for you. A 36-year-old woman has palpitation, weight loss, heat intolerance, and fine tremor. All are examples of increased thyroid in the blood. Now she also has bilateral exophthalmos and a smooth goiter with a bruit. So that means they are pointing towards Graves' disease. Now TSH is suppressed, free T4 is raised, and TRAb is positive. So what do you think the answer is? Is it subacute thyroiditis? It may not be, because they have not mentioned any pain or tenderness at the thyroid gland. Is it Graves' disease? Looks like it. Is it toxic multinodular goiter? Not necessarily with an antibody positive. Sick euthyroid syndrome, the TSH and T4 doesn't match that. Is it factitious thyrotoxicosis? eye signs may not be present in factitious thyrotoxicosis. So here we go. The answer is Graves' disease. Now, why did we arrive at Graves' disease is the answer? Because they have explained that there is diffuse goiter with a bruit, there are eye signs, and there is positive TRAB. Now, this is diagnostic of Graves' disease. Now, you should think about the treatment. What will you offer at this point? You can start with carbimazole, and you should warn against granulocytosis at this point. So, as soon as the patient feels she is sick, she should go to her GP and report sore throat or fever. And we can also offer beta blocker if the patient is having other symptomatic features of tremor, anxiety, tachycardia, and definitive treatment will be radioiodine or surgery. Now, thyroiditis, you could think about it, but in that case, they would talk to you about a painful thyroid with a transient or low uptake on the scan. Toxic nodules will not have eye signs or the antibodies. Coming to the next segment, it is thyroid emergencies. What all thyroid emergencies can you think of that you will be facing in the emergency? You could present with a thyroid storm, though it is more often seen in the theaters. Myxedema coma, which can be seen. Amiodarone, you should remember that because it can cause people who are on amiodarone for cardiac arrhythmias can have both hypo or hyperthyroidism, and there are type 1 and 2. You should remember it. You can expect one question on this as well. So always think about giving steroid alongside thyroid replacement if you think there might be adrenal insufficiency as well. So what do we have to monitor in emergency? So we have to monitor arrhythmias and electrolytes. Another practice question. A 28-year-old with poorly controlled type 1 diabetes presents with vomiting and drowsiness. Okay, the glucose is 28, pH is only 7.18, bicarbonate is 9, ketone is 5.2, and potassium is 5.4. So what do you think this emergency is? So as soon as you see type 1 diabetes, you might think the patient is having, it's quite clear, there is acidosis, ketones are raised, so it could be, and the glucose is raised as well, so it could be diabetic ketoacidosis. So what will you give first? Will you give insulin bolus and then variable rate insulin, or will you treat with saline and then fixed rate insulin, or will you give oral rehydration with subcutaneous insulin, or IV sodium bicarbonate, or IV dextrose and potassium? Yes, so identify the condition first. So like I said, diabetes is there, ketosis is there, acidosis is there. So the diagnosis is quite clear. It is diabetic ketoacidosis. So in diabetic ketoacidosis, we are going to manage the fluids first. So we have to restore circulation, and then we give fixed rate IV insulin, monitor and replace potassium as it falls. So it is not step by step as such. We start fluids, we give fixed rate insulin, and we have to monitor and see if there is potassium depletion and replace that. So in diabetic ketoacidosis, even though you have noted that the bicarb was only 9, we do not initiate bicarbonate treatment. It is not routine because it corrects by itself. When we are correcting the acidosis with insulin, it will correct by itself. So why we start insulin before the fluids is because it could worsen hypokalemia. When you're giving insulin, it will shift potassium into the cells. So we have to monitor potassium and prevent hypokalemia. Subcutaneous insulin, it is not because of the duration of absorptions from subcut administration, it is not given acutely. We would prefer to give IV. Coming to diabetes management and emergency. So in diabetic ketoacidosis, usually expected in type 1 diabetes, there will be ketones, there will be acidosis. So give fluids, give fixed rate insulin, potassium replacement, and treat what caused the diabetes ketoacidosis. So normally it doesn't present isolated. It is usually due to some other reason. Maybe the person had gastroenteritis whereby there was fluid loss, or they skipped their insulin, or if the patient was on an insulin pump, it could be failure of the pump, it could be some other infection which triggered off the diabetic ketoacidosis. So always identify and treat the trigger alongside. Then you have HHS, which is usually seen in type 2 diabetes. They will present with very high glucose. So the primary problem here will be hyperosmolality. Because of the high glucose, they can go very high, but ketones will be minimal. So our priority will be to rehydrate first, cautious insulin and VT prophylaxis, because they can go in very easily for stroke because of hyperosmolality. Hypoglycemia, another condition you would see. So go according to the hypoglycemia protocol, give oral fast carbs and give it 3 times with 15-minute intervals, monitor with CBG or IV glucose if you want to, and then you can go ahead with IM glucagon. IV dextrose can be given if you don't find improvement with oral fast carbs. IV dextrose and, like I said, IM glucagon can be given. Again, look into what is causing the hypoglycemia. Was it alcohol or is there sulfonylurea involved? So manage that accordingly. Now, there are several newer agents that we are using, SGL2 inhibitors, empagliflozin and dapagliflozin, which has got a lot of cardiovascular and renal benefit, and we can find many people on them as a preventive measure for cardiovascular and renal problems. But if they are presenting at least even once with DKA, we try not to give them because they can have euglycemic diabetic ketoacidosis. GLP-1 agonists are also being increasingly offered to help people with type 2 diabetes, which will also aid in weight loss, reduce peripheral resistance, and help in the overall control of diabetes. Now, there are sick day rules. So even if the patient is sick, they wouldn't normally stop insulin, but if they feel they are not eating anything and they don't need to take insulin, that can cause DKA. So even if the patient is not eating insulin, diabetic people with type 1 diabetes they are usually on basal bolus regime. So the basal insulin should always continue. Long-acting insulin should always continue. This is the difference between DKA and HHS. Normally, DKA people are type 1, maybe younger, but you can find it in all age groups. Again, type 2, they are usually seen in older people. The glucose is not very high, it goes just above 11 and above, but if you want to say that a person has HSS, the glucose has to be above 30. Now the ketones are greater than 3 or there will be ketonuria. In HHS, you will not find any significant ketonemia or ketonuria. In DKA, the pH will be less than 7.3 or the bicarbs can be less than 15. So those are the 3 diagnostic criteria you will find in DKA. Glucose greater than 11, ketones greater than 3, pH less than 7.3. Can have variation. The pH can be above 7.3, but bicarb is less than 15. Even then, you will call it DKA, and it develops within hours. It is very quick, whereas HHS will develop over days, and the patient will present with significant dehydration. So remember, in HHS, rehydrate first. You can start off their regular insulin and monitor accordingly, and they are always at a high risk for thromboembolism, so you have to offer them prophylaxis. So in both, we will start with 0.9% saline fixed rate insulin, watch and replace potassium. Along with that, treat the trigger. Another practice question: a 78-year-old with type 2 diabetes presents after days of confusion and reduced oral intake. Glucose is 48, no significant ketone, sodium is 158, osmolality is 350, and the patient presents with AKI. So the picture is quite clear of HHS. Remember, when there is hypernatremia, the reason is always dehydration. The first reason is dehydration, second reason is dehydration, and the third reason also will be dehydration. That is because of hyperglycemia here. So what will you do? Will you start the fixed rate insulin immediately? Will you start with 0.9% saline for rehydration, or give insulin and VT prophylaxis? Will you give sodium bicarbonate here? Will you correct rapidly with 5% dextrose for hypernatremia, or will you give oral hypoglycemics? What will you do? Like we discussed earlier, we have to correct the dehydration. So rehydrate the patient, start insulin, and also offer VTE prophylaxis. So the fluid replacement here is a priority. Insulin is lower dose and you can start it alongside, but first go ahead with fluid replacement. And always remember, risk of thrombosis is quite high in such patients. So aggressive insulin are not going to help you because they will cause rapid osmotic shift, And always remember, sodium should be corrected very, very gradually. Always remember never to correct it more than 8 to 10 millimoles per day in 24 hours, because it can lead to pontine melanosis. So always be aware of that. Coming to adrenal disorders. So what all adrenal disorders are you familiar with for MRCP2? You will have questions on Cushing's syndrome, Addison's disease, adrenal crisis, Conn's syndrome, and pheochromocytoma. Very favorite topics of MRCP. So in Cushing's syndrome, I try to remember Cushing, excess, cortisol excess, isn't it? So to test for Cushing's syndrome, we offer overnight or low dose dexamethasone suppression test. We try to localize with ACTH, and we provide a high dose test for localization. Then there is Addison's disease. So in Addison's disease, you would expect the failure of adrenal glands. So ACTH, remember the axis, ACTH will be high, and that will cause fatigue, pigmentation. So you can have palmar pigmentation, low sodium and high potassium, because adrenaline is responsible for maintaining sodium in the blood. Addison's disease, adrenal deficiency, therefore sodium is low. Proportionately, potassium will go high. Like I said in the beginning, when there is insufficiency of a hormone, we go ahead with stimulation tests. So synthetic ACTH or short synactin test will be offered, and once we have a diagnosis, we will replace with hydrocortisone or prednisolone and fludrocortisone. Now, an adrenal crisis. So you have a patient, it can be the primary or secondary long-term steroids. There is suppression of the axis, and the patient is presenting with hypoglycemia, hypotension, and you suspect an adrenal crisis. What will you do? Do you think you will go in for a short synactin test to establish the diagnosis? No, it is a life-threatening crisis. So you have to offer fluid first and 100 milligrams of IV hydrocortisone. We do not wait for the results. So once the adrenal crisis is resolved, then you can go in and establish your diagnosis with a short synactin test. Now, Conn's syndrome. The stem of the question will be resistant hypertension, young individual. So what will you do next? It will be management. How will you manage, what investigation, and how will you manage type of question stem that you can expect for Conn's syndrome. There will be hypertension, there will be hypokalemia, because Conn's syndrome will have hyperaldosteronism. So hyperaldosteronism means more sodium and less potassium, and we can identify that with a high aldosterone renin ratio. Because of the high aldosterone, it will suppress renin, therefore high aldosterone renin ratio. Now, another disease that you should be familiar with is pheochromocytoma. It will be typical history. Patient presenting with episodic hypertension, episodic headache, sweating, weight loss. So the test will be urinary metanephrines. And remember, for controlling the hypertension in pheochromocytoma, you should offer alpha blockade first and then only beta blockade. Because if you're going to give beta blockers, there will be unopposed alpha stimulation that will create a hypertensive crisis. So always alpha blockade and then beta blockade. So this is a flow chart just to show adrenal insufficiency. So now you have a stable patient, you have managed the crisis, but you think the crisis was a proper adrenal crisis and you're suspicious of an adrenal insufficiency. How will you move forward with it? So you should do a short synactin test. So short synactin test, you can do it anytime, but you need at least 12-hour gap between the last steroid dose. The patient should not be on steroid for at least 12 hours. So you tend to do it in the mornings. You can do it anytime, but mostly in the morning. So we have a cortisol level. We take a cortisol level at 0 minutes, and then we administer 250 microgram of ACTH. When we do that, we wait for 30 minutes and then take another blood. So we have two samples here at 0 minutes and then synactin, and then at 30 minutes. So we are stimulating the gland, and then we look for cortisol rise. Is there an adequate cortisol rise? That means the axis is intact. We can exclude Addison here. If there is no rise there, then there is Addison's disease. We have to replace hydrocortisone and fludrocortisone. So always remember, for crisis, you have to give IV hydrocortisone and fluids first, and do not wait for the results to establish the insufficiency. So the pearl here is, in suspected crisis, like I've told you, do not wait for confirmation, go ahead with IV hydrocortisone 100 mg. Now, how to differentiate between Cushing's and Addison's? Cushing is always excess of the hormone. Addison, ADD, adrenal deficiency. So remember, ADD, adrenal deficiency. Cushing, excess. Okay. So the features of excess hormone is weight gain, striae, bruising, and hypertension. Do you remember that picture in the textbook? Lemon on matchstick appearance? Yes, you will have a buffalo hump, everything in addition. If you remember that, you will remember all these features. Now, because aldosterone will be in excess, you will have high glucose and low potassium in severe cases. So always when the hormone you are trying to find out is in excess, we go ahead with suppression test. Whereas in deficiency or insufficiency, we go ahead with stimulation test. Again, because of the adrenal deficiency, sodium will be low, potassium will be high, and we go ahead with short synactin test or ACTH stimulation. In the in the exercise question before, we also read about pigmentation. So that happens in primary and not in secondary. Can you think why? Because in secondary adrenal insufficiency, ACTH is also low. Therefore, there will not be pigmentation. Whereas in primary Addison's insufficiency, the hormone is deficient. Therefore, the master gland tries to stimulate the gland to produce more. Therefore, there is more ACTH secretion. Along with that, melanocytes are also stimulated, and therefore, there will be pigmentation. Next practice question. A 42-year-old patient presents with vomiting, hypotension, and abdominal pain. Sodium is only 126. Potassium is 6.1, glucose is only 3.2, and you can see buccal pigmentation. And he recently stopped long-term steroids. The patient is presenting with a very clear diagnosis. You can see hypotension, hypoglycemia, low sodium, high potassium, and there is pigmentation. Okay, and another biggest clue is he recently stopped his long-term steroids. So when a patient is taking long-term steroids, we have to expect suppression of the hormonal axis. So how will you treat this patient? So now we know he is in a crisis. This is adrenal crisis. Will you give IV hydrocortisone and IV saline, or will you wait for a 9 a.m. cortisol? Would you go ahead with the oral fludrocortisone for his hypotension, or would you give IV insulin dextrose for high potassium, or would you do CT right away before treatment? Yes, so since the patient is in adrenal crisis with hypotension, low sodium, high potassium, hypoglycemia, and pigmentation, we have to treat immediately. So that is IV hydrocortisone and saline now. Do not delay tests. So often people who have established adrenal insufficiency or Addison's disease will be provided a pen with hydrocortisone, so they can take it immediately when they feel they are going into crisis. So the paramedics are trained to do that as well. So often before reaching the hospital itself, they would have got their hydrocortisone and they would be on a bag of fluids. Coming to pituitary disorder. So master gland, we've reached master gland. So master gland, we need to know plenty of hormones because it is involved in secreting 6 major hormones. So we have to remember about acromegaly. So that is growth hormone excess. So the features they will give you will be prognathism. They will tell you their rings are getting tighter. They had to change their shoes, buy shoes several times in the last 2 or 3 months. All this is because of excessive growth hormone. You would expect to find raised insulin-like growth factor 1. That is a screening test, and to confirm that, oral glucose tolerance test will be used. So failure to suppress a GH will be confirmatory in acromegaly. Prolactinoma. So prolactinoma, the clinical features will be galactorrhea, amenorrhea, low libido, and the treatment will be cabergoline, which is a dopamine agonist. That is the first line. You can go in for surgery later on when cabergoline fails, or when there are pressure symptoms, you can go in for surgery. Hypopituitarism, so that is multiple hormones. All of those hormones will be in trouble. But we always give importance to replacing steroids before levothyroxine. Non-functioning adenoma, so mainly it is just a structural problem, so it will cause mass effect. So the history, they will give you bitemporal hemianopia and other hormonal deficiencies. The investigation will be MRI, treatment will be surgery. Apoplexy, so that will be, the history will be sudden headache, visual loss, hypopituitarism. The treatment will be steroids and urgent imaging. This is the hypothalamic pituitary axis. Hypothalamus is here. We have anterior pituitary and posterior pituitary. Anterior pituitary is responsible for the production of 5 major hormones: ACTH, not 5, 6 actually, ACTH, TSH, LH, FSH, GH, and prolactin. We know ACTH is responsible for the adrenal axis, thyroid for the thyroid axis, luteinizing hormone and follicle stimulating hormone are gonadotropic releasing hormone, gonadotropins. Then we have growth hormone, which will cause rise in insulin-like growth factor, and prolactin. Posterior pituitary is responsible for oxytocin and ADH, antidiuretic hormone. Always remember, bitemporal hemianopia plus hypopituitarism is often macroadenoma, and investigation is MRI. Practice question. A 32-year-old woman, she has amenorrhea, galactorrhea, low libido. Prolactin is markedly elevated. TSH is normal. MRI shows a 6 mm pituitary microadenoma. What will you do? Will you go ahead with the transfemoral surgery? Will you go ahead with cabergoline? Would you go ahead with radiotherapy, levothyroxine, OCP? What would you do? So I would like to add something here. Sometimes they will give all this and there will be one option: check pregnancy. Always check pregnancy in a fertile woman, because that by itself can cause raised prolactin. Once you have established that is not the cause, then you can treat the microadenoma. It is cabergoline. So prolactinoma, they respond to cabergoline most of the time, and they will help in shrinking the tumor. Although treatment may be prolonged, it may take 2 to 3 years sometimes, but as long as it is shrinking the tumor, we are good with it. We go ahead with surgery when it is not responding or there is acute compressive symptoms related to the macroadenoma. Then we go ahead with surgery. Coming to sodium, water, and posterior pituitary, because ADH is involved here. Okay, so you have a patient and the patient's sodium is only 125, say in that range, in 120 to 125 range. How will you treat this patient? Will you directly go in for fluids, or are you going to give diuretics, or how is it going to be? So first of all, establish why there is hyponatremia. Okay, go ahead with other tests. You need to check thyroid function test. You need to check the lipids. You need to check whether there is hyperglycemia. All that you have to check. In addition, of course, the renal function, liver function, and BNP also you need to check. Now establish if the patient is having normal volume, if the patient is hypovolemic or hypervolemic. So reasons for hypervolemic is quite simple. They will be in all sorts of failures. There will be liver failure or renal failure or cardiac failure. Give a diuretic or treat as necessary, and the sodium will return to normal. It is because of the excess fluid that you have hyponatremia. Now for hypovolemia, is it because of diarrhea or vomiting? Replace fluids and sodium will be corrected. Now coming to euvolemia. So you feel the patient is having euvolemia, but the sodium is still low. Now you need to check osmolality. You need to check serum osmolality, you will need to check urine osmolality and urine electrolytes as well, urine sodium and potassium. So remember, in syndrome of inappropriate secretion of ADH, there will be low serum osmolality, okay, and there will be concentrated urine. That will be the osmolality will be greater than 100 or to 300, and the serum osmolality will be less. So you need to treat the cause for SIADH. What causes SIADH? It could be trauma, it could be cancer, Could be a number of causes, even illness. So you need to treat the cause, and often it is fluid restriction, which will correct. You can restrict the patient's fluid intake to 1.5 liters or 1 liter or less than 0.5 liters according to the solutes or urine electrolytes. Urine sodium, actually, it will be greater than 20 to 30 to say that it is SIADH. Now coming to diabetes insipidus, the major symptom will be polyuria. Lots and lots and lots of urine, very dilute urine, and the patient will be drinking water accordingly. So now you are wondering whether it is polygenic polyuria, polydipsic polyuria. So you need to do a water deprivation test. So for water deprivation test, we try to restrict their intake of water, and we monitor their osmolality, plasma and urine osmolality, and then we try to give desmopressin and try to observe the response to desmopressin, and you can know whether it is cranial or nephrogenic. Always remember, correct the sodium very slowly, because rapidly, if you correct, it will definitely lead to osmotic demyelination, which is quite an irreversible condition. You can't do anything about it. So always correct sodium very slowly. Next, you need to think about drugs which can cause hyponatremia. Often it could be SSRI or carbamazepine or thiazides, and all those will cause hyponatremia as well. So this is just again a flow chart. Like how I said, hyponatremia, when you find the symptom in a patient, see whether the patient is hypovolemic. It could be because of diarrhea and vomiting, excess diuretics, Addison's disease, salt wasting. Then euvolemia, it is usually because of syndrome of inappropriate secretion of ADH. Hypothyroidism and adrenal insufficiency can cause it as well. And hypervolemia in various failures, heart failure, liver failure, renal failure, nephrotic syndrome. Practice question. A 70-year-old with small cell lung cancer is very confused. Sodium is only 118. Serum osmolality is low. Urine osmolality is high. Urine sodium is high as well. She is euvolemic and she is not on any diuretics. First clue, she is euvolemic. So whenever a patient is euvolemic, you need to now know the osmolality. Question says the patient's serum osmolality is low and urine osmolality is high. Urine sodium is also high. So this clearly says the patient might be in SIADH. So there is another clue here, small cell lung cancer. So it could be a parathormone related hyponatremia as well. So what will you do? Will you give hypertonic saline right now? Will you restrict fluids, or will you give IV saline, 2 liters stat, desmopressin, or will you give fludrocortisone? It is SIADH. So you would go ahead with fluid restriction. Euvolemia, low serum, high urine osmolality, high urine sodium, that is SIADH. For that, you need to restrict the fluid and treat the cancer. So if you give saline at this point, it can worsen SIADH. And you do not give hypertonic saline at this point, only if the patient is symptomatic with seizures and a lot of confusion and severity, highly very, very severe symptoms, then only you will go ahead with hypertonic saline. Otherwise, no. And that too, you need to give it in ICU and not otherwise. Coming to calcium, parathormone, and bone metabolism. So here you need to know about primary hyperparathyroidism, malignancies, hypoparathyroidism, men's syndromes, osteoporosis, and osteomalacia. So in primary hyperparathyroidism, PTH will be high and calcium will be high as well, and it is usually caused by parathyroid adenoma, and depending on how bad the symptoms are, we will decide whether to go ahead with medication or with surgery. In malignancy also you will find high calcium, but in that case there will be a negative feedback and parathormone or PTH will be low, and the high calcium is because of parathormone. And here you will treat the hypercalcemia with fluids and bisphosphonate. After ensuring vitamin D levels are normal, you can give IV zoledronate to reduce calcium if it is not being treated with just IV fluids alone. In hypoparathyroidism, calcium will be low because of a low parathyroid hormone. That is seen usually post-thyroidectomy. So you will need to give calcium and vitamin D, active vitamin D for this. Now, MEN syndromes, we have MEN1 and MEN2. MEN1 will involve tumors of the parathyroid, pancreas, and pituitary, whereas an MEN2 will involve medullary thyroid cancers, pheochromocytoma, and parathyroid tumors as well. You also need to know how to distinguish between osteoporosis and osteomalacia, know how to, where vitamin D is low and where calcium phosphate might be low. So this is how to differentiate between various parathyroid abnormalities. First, you have secondary hyperparathyroidism. So in secondary hyperparathyroidism, it is usually seen in CKD or in vitamin D deficiency. So what happens there? There will be reduced calcium absorption because of the enzyme not being activated, alpha hydroxylase enzyme not being activated in chronic kidney disease, and hence you do not have the active form of vitamin D, which is calcitriol or 1,25-dihydroxycholecalciferol, because of which you have reduced calcium absorption, and that will lead to a compensatory high parathyroid hormone. So that is called secondary hyperparathyroidism. Here calcium will be low, and hypoparathyroidism by itself will have a low calcium and low parathyroid hormone. In primary hyperparathyroidism, you will have high calcium, which is caused due to high parathyroid hormone, and in malignancy you will have high calcium but the parathyroid hormone will be reduced. It can be seen in vitamin D excess as well, where the parathyroid hormone will be reduced but the calcium will be high. Practice question: 62-year-old with metastatic breast cancer is confused and constipated. Now, calcium is 3.5 millimoles per liter. Phosphate is low, normal, within no normal range. PTH is suppressed and renal function is preserved. So this gives you an idea of what it might be, what kind of hyperparathyroid or hypercalcemia it is because of. Is it malignancy? Is it due to chronic kidney disease? What is it due to and how will you treat? So you have to give IV saline and then IV bisphosphonate, because this hypercalcemia has been caused because of malignancy, as evident by a high calcium level and low parathyroid level. So you need to aggressively treat with IV fluids, and then when the patient is stabilized, you can offer bisphosphonate once vitamin D levels are normal. Now, bisphosphonate levels are too slow usually, and we do not give loop diuretics as first line. Only after rehydrating the patient aggressively, if you feel the patient is going to go in for volume overload, then you need to add loop diuretics for that. And surgery we offer for primary hyperparathyroidism and not for secondary. So this is a rapid recap. So always pair target and trophic hormone to localize whether it is a primary or a secondary disease. For diabetic ketoacidosis, rehydrate first, insulin, pay attention to the potassium, whereas in HHS, rehydrate first. In adrenal crisis, go ahead with IV hydrocortisone, stat and fluids before doing the test to confirm adrenal insufficiency. And if there is a bitemporal hemianopia in the stem, it is usually because of pituitary, prolactinoma, macroadenoma. MRI treatment will be gabapentin or surgery depending on the situation. When there is a high calcium and low parathyroid hormone, it is often because of malignancy, and you can also have syndrome of inappropriate secretion of ADH. The treatment is fluid restriction in SIADH, whereas in hypercalcemia of malignancy, it is aggressive rehydration. Practice question: a 48-year-old reports increasing ring and shoe size, coarse facial features, sweating and headaches with bitemporal visual field loss. Insulin-like growth factor 1 is markedly raised. How will you confirm the diagnosis? So what is the diagnosis first? Sounds like acromegaly, doesn't it? Increasing ring and shoe size, coarse facial features, it could be prognathism, sweating and headache, and there is bitemporal visual loss, and the screening test is positive, which is insulin-like growth factor 1. So how will you treat this patient? Is it or confirm the diagnosis? Is it a single random growth hormone level, or OGTT with GH measurement, dexamethasone suppression test, short synactin test, 24-hour urinary metanephrine? How will you go ahead with this? So it is OGTT with growth hormone measurement. So it is confirmed by the failure of GH to suppress during an OG. So glucose should reduce the secretion of growth hormone. So when the growth hormone is being secreted by excess from the gland, giving a shot of glucose is not going to reduce it. And we confirm acromegaly with this test. How will you investigate further? You have to look at MRI, pituitary. Treatment will be transfemoral surgery. Because the patient is already having pressure symptoms, we cannot wait for it to go ahead with somatostatin analogs. But it is often offered along with it so that the size will reduce concurrently while the surgery is being planned. Now, 40-year-old has episodic headache, palpitation, pallor, drenching sweats with paroxysmal severe hypertension. Plasma metanephrones are markedly raised and CT shows a 4 cm adrenal mass. So symptoms are classic of pheochromocytoma, confirmed by plasma metanephrones, and CT imaging also shows a 4 cm adrenal mass. So for this hypertension, how will you treat? Will you give propranolol, or will you start phenoxybenzamine, which is alpha blockade? Will you go ahead with immediate adrenalectomy? Will you offer spironolactone or ramipril? Like I said before, always give alpha blockade first and then only give beta blockade, because if you give beta blockade alone, it will cause unopposed alpha stimulation and will lead to a hypertensive crisis. Surgery will be planned later on. Once you establish and make the patient stable, then you can plan for surgery. Another practice question. 45-year-old has resistant hypertension and hypokalemia despite no diuretics. Aldosterone-renin ratio is high. CT shows unilateral adrenal adenoma. So note the point. Young patient, 45-year-old, resistant hypertension and hypokalemia. You can also find metabolic alkalosis in Conn syndrome. This is Conn syndrome because the aldosterone is to renin ratio will be high, and CT is also showing adrenal adenoma. So the answer is obviously primary hyperaldosterone. It is Conn syndrome. So you have hypertension, hypokalemia plus high aldosterone to renin ratio. It is Conn syndrome. So if it is unilateral adenoma, you can go ahead with an adrenalectomy. But if it is bilateral, then we can do only symptom control. In addition to other antihypertensives, you can add spironolactone and eplerenone, because it will also prevent hypokalemia at this point. So this is a reminder for our upcoming PACEs. We are having a 2-day live on-site course in which we'll have 2 full circuits. It will be depicting the real exam. We'll have expert examiners here, trained role players. We'll be giving you personalized feedback for each station, and we'll be helping you with the time management as well. And if you would prefer a 1-to-1 course after your MRCP 2 successfully when you complete it, when you're planning 1-to-1, it is very effective. We'll have an expert 1-to-1 mentorship. Personalized feedback will be offered, guided. You will be personally guided as well. You'll have face-to-face online mock sessions and complete PACEs circuit. Those interested can contact us later on. So now coming to renal medicine. In renal medicine, you can expect 19 questions again, just like endocrine. It is equally important. So, examination approach. Always try to separate AKI from CKD using the baseline creatinine. Okay, kidney size, which will be small and chronic kidney disease, anemia, and bone disease. All this will indicate chronicity. Look at urine analysis. Look at blood and proteinuria, cast, and urine sodium, which will again help you in the diagnosis. Always exclude obstruction with the help of a bladder scan or ultrasound KUB and stop the nephrotoxins. Look at electrolytes and acid base picture, which is necessary to drive the urgent management, like to decide when the patient needs dialysis and know the dialysis indications and when to refer urgently. So you should know what indicates dialysis. So there is an easy way to remember treatment for AKI. I remember with STOP. S is for stop the nephrotoxins. T is for evaluation of other toxins in blood causing AKI. O is for ruling out obstruction, and P is to look for parenchymal diseases leading to AKI. So reasons for AKI or causes of AKI is always pre-renal, renal and post-renal. Pre-renal means it is because of hypovolemia due to so many causes. It can be because of diarrhea, it could be because of sepsis, it could be cardiorenal, it could be hepatorenal, it could be drug-induced, and they always respond to fluids. Intrinsic can be because of acute tubular necrosis, which is very common, glomerulonephritis, interstitial nephritis, and vasculitis. They are parenchymal diseases causing AKI. Post-renal is because of obstruction like stones, prostate hypertrophy, tumor, which will lead to hydronephrosis, increase in back pressure, decreased GFR, and we can see evidence on ultrasound or CT. Interstitial nephritis is usually drug-induced that we see quite commonly because of proton pump inhibitor abuse, NSAIDs or antibiotics, and in the question stem you will be given eosinophilia or rash mostly. Management of AKI is treat the cause, optimize volume, stop nephrotoxins, manage potassium because the patient can very quickly go in for hyperkalemia and cardiac arrhythmia, and always look after the patient and see if dialysis is indicated. Again, a flow chart depicting reasons or causes of AKI. Pre-renal, which can be because of hypoperfusion, that is hypovolemia, sepsis, cardiorenal, NSAIDs or ACI. Intrinsic because of acute tubular necrosis, glomerulonephritis, interstitial nephritis and vasculitis. And post-renal in obstruction caused by stones, prostate or tumor, which will cause a hydronephrosis. So always exclude obstruction like I said before. Now when you feel a palpable bladder or hydronephrosis, always relieve the obstruction with a catheter, or if indicated a nephrostomy if it is a big stone and you can't do anything about it, quite urgently. So practice question, a 68-year-old develops AKI. Creatinine is 280 now. Baseline was only 92 weeks ago after starting a PPI. There is also a maculopapular rash. There is a low-grade fever and urine eosinophils, but the ultrasound is normal. What do you think this disease might be? Is it acute tubular necrosis? Is it acute interstitial nephritis? Is it pre-renal AKI, obstructive uropathy, or rapidly progressive glomerulonephritis? Quite evident, isn't it? It is acute interstitial nephritis. So what happened here? So a new drug was started, which is PPI, and in 2 weeks the creatinine went up from 90 to 280. In addition, there is rash, there is fever, there is eosinophils. So it is clearly interstitial nephritis. How do we treat this? We stop the drug and we can think of steroid if the patient is not responding afterwards. So in tubular necrosis, we are talking about interstitial nephritis before, but in tubular necrosis, you will not have allergic features. Okay, there will be the rash will not be there, fever will not be, eosinophils will not be there, and the obstruction will show hydronephrosis. So in tubular necrosis, the cells in the tube will slough off, okay, and they will mimic an obstruction there, which will cause hydronephrosis. Now coming to CKD, chronic kidney disease and complications. So you need to know the staging based upon EGFR. There will be albuminuria, slow progression. All that can be prevented with ACIs or ARB. Anemia. How do you treat anemia in CKD? What do you do with erythropoietin stimulating agents? How to replace, when to replace. For example, if the patient is having chronic anemia and that is because of CKD, will you directly go in for iron infusion or iron tablets, or will you check ferritin first? Remember, in CKD, for treating anemia with erythropoietin stimulating agents, you need to check ferritin. Only if they are above 100, erythropoietin will work. Otherwise, you will get only the side effects of erythropoietin and treatment of anemia will suffer. And then mineral bone disorder. Like I explained before, in CKD, you would expect to get mineral bone disorder because of lack of the enzyme which is involved in metabolism or conversion of inactive vitamin D to active 1,25-dihydroxycholecalciferol. Because of lack of active vitamin D, absorption of calcium is significantly impaired, and that will affect the bone density. And there will also be a high phosphate because it is CKD. The phosphate will not be excreted as effectively, and there will be a high phosphate as well. And because of the low calcium, you will have secondary hyperparathyroidism. Now, you would tend to think that the person with CKD might die of CKD, but actually it is a cardiovascular problem which is a leading cause of death in CKD. So when the patient is having CKD, we must always avoid or adjust nephrotoxic drugs. So even if the patient is in CKD and needs an antibiotic which is renotoxic, we cannot often have a proper antibiotic which we can give there, but we have renally adjustable doses of the same antibiotic which is less harmful, and think about giving that, and often reduce or adjust the dose of renally excreted drugs like metformin and gabapentin. Practice question. 60-year-old patient with CKD in stage 4 has a hemoglobin of 88, ferritin of 40, transferrin saturation 12, and the patient is symptomatic now. The shortness of breath probably. So, and the renal function is stable. Will you start an ESA immediately, or will you replace iron first and then reassess for an ESA? Or will you go ahead and transfuse 2 units? Will you start a bisphosphonate, or will you give vitamin B12? What will you do here? Again, the answer, it has been explained prior. So we have to replace iron first because ferritin was only 40. So at least it has to be 100. And while continuing with the ESA, you need to see that it is between 100 and 400 before continuing with the treatment. They're not as effective with low iron stores, and transfusion is reserved for very severe or symptomatic anemia. Coming to glomerular disease. Glomerular disease, you have nephrotic syndrome, nephritic syndrome. Common causes of these syndromes: rapidly progressive glomerulonephritis and complications of nephrotic syndrome, type of questions which you can expect. So nephritic syndrome. In nephritic syndrome, the patient will present with hematuria, hypertension, RBC cast in urine, only mild proteinuria. So the causes are quite simple. It can be post-streptococcal glomerulonephritis, IgA nephropathy, vasculitis. Nephrotic syndrome, remember the O's: proteinuria, hypoalbuminemia, edema. Because of hypoalbuminemia, there will be hyperlipidemia, okay? And because of the loss of antithrombin 3 as well, that's also a protein, isn't it? So you'll have hypercoagulability at this point. So you need to give vascular, because the patient is at high risk for thromboembolism, you need to offer anticoagulants. Common causes for nephrotic syndrome can be minimal change disease in children, focal segmental glomerulosclerosis, membranous nephropathy, and systemic diseases like diabetes and hypertension can also cause nephrotic syndrome. Rapidly progressive glomerulonephritis, you will find crescentic glomerulonephritis because of vasculitis mainly and antibodies, and because it is related with antibodies, it will require urgent immunosuppression. Complication, like I said, because of the loss of gamma globulins as well along with antithrombin 3, you can have increased risk of infection, and this can lead to AKI. How to differentiate between nephritic and nephrotic syndrome? So nephritic is hematuria plus cast, RBC cast, hypertension, oliguria or mild proteinuria, and the reasons are IgA nephropathy, post-streptococcal glomerulonephritis, and vasculitis. Whereas in nephrotic syndrome, heavy proteinuria greater than 3.5 grams per day, hypoalbuminemia, which causes edema, and hypoalbuminemia will lead to hyperlipidemia as well, and the causes are minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. So because of the nephrotic complications, you need to give vascular prophylaxis, prophylaxis for thromboembolism. Increased infections can be seen, and AKI can also present at this point. So by thrombosis, you can expect questions with renal vein thrombosis. The patient presenting with nephrotic syndrome, sudden pain, all that will show you that the patient has gone into renal vein thrombosis or having renal vein thrombosis. Now, how to differentiate between the nephritic syndromes, okay? So all this will have hematuria and hypertension and low protein, this IgA nephropathy and post-streptococcal nephropathy. You can differentiate by time between the infection and development of hematuria. If hematuria develops within days after URTI, like within 2 to 3 days, then it is mostly IgA nephropathy. It is quite common. Okay, post streptococcal glomerulonephritis, you will have hematuria. The patient will develop hematuria close to 2 weeks after infection, and it will be associated with low complement, and it is self-limiting. For minimal change disease, it is the most common reason of nephrotic syndrome in a child, which is responsive to steroid. In membranous nephropathy, it is a reason for nephrotic syndrome in an adult, but this will involve antibodies. Therefore, you should look for anti-PLA2R antibody, and also often associated with malignancy or drugs. Practice question: 24-year-old develops frank hematuria 2 days after sore throat. Now, BP is high, mild ankle edema, and the urine shows red cell cast and modest proteinuria. Complement is normal. So the answer is quite obvious. This is not post-streptococcal because it is too early. It is not 2 weeks, and complement is normal as well. So it takes us away from post-streptococcal glomerulonephritis, and the answer is IgA nephropathy. Because of normal, and it is often called synpharyngitic because it comes before the symptoms of pharyngitis or upper respiratory tract symptoms resolve, you will get IgA nephropathy symptoms. So it is called synpharyngitic. Next question: 48-year-old presents with periorbital and leg edema. The urine protein creatinine ratio is very high. Albumin is 18, that is hypoalbuminemia. Cholesterol is raised, that is hyperlipidemia. And now the patient suddenly develops flank pain and there is AKI. So it is all OOO, isn't it? Periorbital and leg edema, proteinuria, hypoalbuminemia, and hyperlipidemia. So what would you think it is? It is anyway nephrotic syndrome. Now you have to think about the complication of nephrotic syndrome, one of which is renal vein thrombosis complicating nephrotic syndrome. I don't think it is acute tubular necrosis because there are no other features of obstruction that they have told. Renal calculus will have flank pain, but not so much edema and hypoproteinemia and proteinuria. Pyelonephritis, no, there is no fever or any other indication of infection here. Or is it renal artery stenosis? I don't think so. That will give you a different picture. So the answer is renal vein thrombosis. So nephrotic syndrome is prothrombotic. Okay, because the antithrombin 3 is lost, there will be flank pain and AKI in renal vein thrombosis. So how do we proceed with it? We have to do imaging to confirm the diagnosis, and treatment is anticoagulation. Now coming to electrolytes and acid-base balance. Remember hyperkalemia treatment. Okay, the signs will be in peak T waves, wide QRS, and then finally sine waves. We have to treat it immediately. It is an emergency. So treatment of hyperkalemia will involve stabilizing the heart first with calcium gluconate, and then administration of insulin dextrose infusion, and then finally using medication like Lokelma or sodium zirconate to remove the potassium. You can also add salbutamol alongside insulin dextrose infusion. Now coming to metabolic acidosis. So when you find the pH is showing metabolic or pH is showing acidosis and you confirm that it is metabolic acidosis, you need to calculate the anion gap, because the reasons or causes of high anion gap metabolic acidosis, HAGMA, versus normal anionic gap metabolic acidosis, that is NAGMA, is different. You know the mnemonic, mud piles for high anion gap metabolic acidosis, and for NAGMA it is hard up. I'm sure you all are familiar with the mnemonic. There is renal, you need to consider renal tubular acidosis as well. We have type 1, type 2 and type 4. There is no type 3. Remember, type 4 will have hyperkalemia. Okay, it is usually aldosterone failure or aldosterone resistance, and there will be hyperkalemia. In type 1 renal tubular acidosis, which is the failure to failure in reabsorption, I think, or failure to excrete hydrogen ions, which will cause excess hydrogen ions in blood leading to acidosis. There will be type 1. This is type 1 RTA, and you will have stones. You can expect stones here, and the question stem, you can expect stones, type 1 RTA. In type 2, which is which involves a proximal tubule, you will have type 2 RTA, and the example is usually Fanconi syndrome. When there is hypokalemia and alkalosis, that is metabolic alkalosis with hypokalemia, you need to consider, is it because of vomiting, is it because of diuretic, is it because of Conn syndrome, is it Bartter or Gitelman? Remember magnesium ions to differentiate between Bartter and Gitelman. Also, when there is hypertension along with hypokalemic metabolic acidosis, don't forget Liddle syndrome. So these are the ECG changes that you can expect in hyperkalemia. So initially there is a tall T wave, then there are widened QRS complexes, and finally you will have a sinusoid wave. So first thing is to protect the heart using IV calcium gluconate. Then there will be a shift of potassium to the cells using insulin dextrose, and finally you can remove the potassium using potassium binders such as sodium serpinate or Lokelma, and you can use dialysis as well. There is a criteria for going into dialysis in hyperkalemia. So if there are ECG changes and potassium is greater than 6.5, you need to treat immediately. Now, practice question. A dialysis patient missed a session and is feeling quite weak. Potassium is 7.1. ECG is showing tall tented T waves and the QRS is slightly starting to broaden. BP is stable. What will you do? Will you just go ahead with calcium resonium, or will you give IV calcium gluconate and then insulin dextrose? Will you just give nebulized salbutamol? Will you go ahead with an urgent CT, or will you give IV sodium bicarbonate alone? So you should go ahead with IV calcium gluconate and then insulin dextrose, because our primary importance in hyperkalemia is to prevent or avoid a cardiac arrest because of hyperkalemia. So you need to stabilize the myocardium with calcium gluconate, and then go ahead with shifting the potassium inside to the cells from the blood, and then finally excreting them from the blood using stabilizers or binders, potassium binders. Okay, but usually binders are quite slow and insufficient, and since the patient is already on dialysis, it is better to go ahead with hyperkalemia treatment and arrange for dialysis simultaneously. Now, renal vascular disease, hypertension and stones. So for renal artery stenosis, the patient will show resistant hypertension, flash pulmonary edema and AKI on starting AC inhibitors or ARB inhibitors. Suppose the patient came in with resistant hypertension and you started the patient on ACE inhibitors or ARBs, and then you're checking, or the patient presents to you with acute pulmonary distress, then it is renal artery stenosis. Now, fibromuscular dysplasia, it is usually seen in young women, and on angiography you can find string of beads appearance. Secondary hypertension, the reasons are Conn syndrome, which is primary hyperaldosteronism. Please do not confuse. Conn syndrome is a reason for secondary hypertension, but it is primary hyperaldosteronism. Pheochromocytoma, Cushing's disease, renal disease, coarctation of aorta, all this will lead to secondary hypertension. In the history for stones, it will be colicky pain, loin to groin in nature. CTKUB will confirm the diagnosis, and we can manage by the site of the stone or size of the stone. And also we need to differentiate between urate and calcium types. Cholesterol embolism, after angiography, if the patient presents with AKI with libido reticularis and eosinophilia, you should think about cholesterol embolism. So the clue here is, if there is an AKI after starting immediately in a week or few days time of starting an ACE inhibitor, you should suspect bilateral renal artery stenosis. Okay, the key is bilateral here. Practice question. 72-year-old with resistant hypertension develops a rise in creatinine from 95 to 190 within a week of starting ramipril. There is an abdominal bruit and he is known to have peripheral vascular disease. What will you do? Will you continue ramipril and recheck in a month? Or do you suspect bilateral renal artery stenosis here? Do you think this is acute interstitial nephritis or diabetic nephropathy? Or do you think this might be minimal change disease? So there is a steep rise in ACE inhibitors, after using ACE inhibitors. So normally after starting ACE inhibitors for patients, sometimes you can expect a rise in creatinine, but if it is less than 25 to 30, that is fine, you can continue. But here in this case, there is a steep rise and there is a bruit with history of vascular disease. So this will point towards renal vascular disease. So what do? We have to stop these inhibitors. We need to do imaging for the renal arteries and revascularize if required. Dialysis and transplant. So like I said, there is always a criteria to offer dialysis, for offering dialysis for a patient. It's quite easy to remember. It is acidosis, electrolyte imbalances, intoxication, overload, and uremia. A, E, I, O, U, your vowels. Okay, acidosis means pH less than 7.1. Hyperkalemia is not just hyperkalemia, it is resistant or refractory hyperkalemia. You are trying to treat the hyperkalemia, but it's not coming down. Okay, intoxication with other chemicals or drugs like methanol. Overload, it can be volume overload and the patient is having pulmonary edema, and then uremia. Okay, so all these are reasons for or indications of starting dialysis. Now it could be either hemodialysis or peritoneal dialysis, depending on what the patient, or there is a lot of factors which will decide whether the patient will go in for hemodialysis or peritoneal dialysis. Now, transplant, it will have the best outcome for a patient, but it will involve lifelong immunosuppressions using calcineurin inhibitors and other immunosuppressants, which by itself can cause several other side effects which you should be aware of. Now, immunosuppression risk. So you should be aware about infection with CMV or PCP, malignancy associated with immunosuppressions, which is PTLD, skin malignancies, and nephrotoxicity also can be expected. For vascular access, we always prefer an arteriovenous fistula. So this is a table showing indications for urgent dialysis. Like I said, it is A, E, I, O, U, the vowels. A is for acidosis, which is severe and refractory. Electrolytes, which is refractory hyperkalemia. You are treating hyperkalemia in spite of which it is not going down. The levels are not falling. Intoxications like lithium, salicylate, methanol. Overload, which is causing refractory pulmonary edema. And uremia, which is resulting in encephalopathy and pericarditis. Patient with AKI has pulmonary edema, unresponsive to high-dose IV furosemide. Potassium is 6.8 despite medical therapy, and pH is 7.10. And they are becoming drowsy now. So almost all the criteria is fulfilled, isn't it? Overload is there, encephalopathy is there, refractory hyperkalemia is there, acidosis is there. Okay, so if you give further furosemide, will you arrange for urgent hemodialysis, oral calcium resonium, IV fluids, or will you repeat insulin dextrose? So the answer is urgent hemodialysis, because there is refractory hyperkalemia, there is overload, there is severe acidosis, there is drowsiness as well, so which indicates encephalopathy. So it meets the dialysis criteria. Therefore, you need to go ahead with that. So giving more diuretic or medical therapy alone, it is not insufficient. You can continue with your hyperkalemia management as it is being arranged, but it is not going to be sufficient. So for renal, we have a rapid recap now. For every AKI, remember stop. S is for stop the nephrotoxins, T is for look for toxins causing AKI, O is for ruling out obstruction, and P is for knowing if the patient is having any parenchymal renal disease or not. In acute interstitial nephritis, you will have history of drug intake. The patient will present with a rash, there will be fever, there will be eosinophils in urine. Acute tubular necrosis is the most common intrinsic AKI. Okay, IgA will have hematuria along with upper respiratory tract infection within days, whereas in post-streptococcal it will be 2 weeks later associated with a low complement. And in hyperkalemia treatment, you are going to offer calcium first. Okay, then shift the potassium intracellularly and then remove it from the body. That is a principle of treatment of hyperkalemia. Now, always AKI, if you are seeing AKI after ACE inhibitors, consider renal artery stenosis, and if required, the patient is satisfying indication for dialysis, consider dialysis as well. Remember the mnemonic AEIOU. Okay. Practice question. 35-year-old with hypertension and strong family history of renal failure. He's got bilateral palpable flank masses and hematuria. Ultrasound is showing multiple bilateral renal cysts, and there is one relative who's had a subarachnoid hemorrhage. So what do you think this is? Is it simple renal cyst? So they're already telling you it is bilateral renal cyst. Is it AD-PKD? Could be, because bilateral palpable flanks, there is hematuria, multiple bilateral renal cyst, and history of subarachnoid hemorrhage as well. So is it medullary sponge kidney? Unlikely with all these features. Acquired cystic disease? Again unlikely, because there is history of cysts elsewhere. And is this tubular sclerosis? They are not giving us any history of other CNS features. So the answer is autosomal PKD. So the stem has bilateral cyst, there is hypertension, there is family history, there is barrier hepatic cyst, and mitral prolapse can also be seen in AD-PKD. So how do we treat AD-PKD? So the primary thing is to control hypertension, okay? And we can consider tolvaptan because it is shown to progress the slow down actually the progression of cyst development, and relatives can be screened. That is a criteria for why they should be screened. Only in certain conditions they need to be screened. As example, for donation of a kidney, for transplantation, or if the patient is going for professions which will require screening, then they can be screened. Otherwise, after 20 years, they can go in for ultrasound to diagnose AD-PKD. Another practice question: an elderly man found after long lie, so now has AKI. Potassium is 6.2. There is markedly raised creatine kinase, dark urine which is positive for blood but shows few red cells on microscopy. Long lie means rhabdomyolysis. When you lie down in one position without changing, it will lead to rhabdomyolysis, and because of that, there is AKI now. Potassium is also high because of rhabdomyolysis, because creatine kinase is also quite high. Another hint here is dark urine. It is positive for blood but shows few red cells in microscopy. So in urine dipstick, it is not able to distinguish between hematuria and rhabdomyolysis. So they are giving us a clue that this is rhabdomyolysis. So how do you treat rhabdomyolysis? You are going to aggressively give fluids to flush it out of the system, okay, and monitor myoglobins out of the system, monitor and treat the hyperkalemia very closely. Next practice question: we have a 70-year-old patient with vasculopathy who develops AKI, livedo reticularis, and discolored toes after 1 week after coronary angiography. There is peripheral eosinophilia and there is a low complement. So how did the AKI happen here? Is it pre-renal, renal, or post-renal? What is happening here? Is it contrast-induced nephropathy? Is it cholesterol, atherosclerotic disease? Is it acute interstitial nephritis, renal artery stenosis, acute tubular necrosis? So I'm sure you would have thought it would be either acute interstitial nephritis or cholesterol, atherosclerotic disease. We can strike off acute interstitial nephritis here because there is no history of any new drug or PPI in particular. And there is peripheral eosinophilia, there is low complement and discolored toes with livedo reticularis. All these are typical presentation of cholesterol embolization. So very typical history. They will tell you about angiography, and this AKI developed after angiography, and all these features of eosinophilia, livedo reticularis, discolored digits, and low complement. It is a classic atherosclerotic disease. We just need to give supportive care and statins, and to avoid further interventions or anticoagulation when possible. So this is a table of never think or never do and always do. Never give insulin before fluids or potassium in diabetic ketoacidosis. Never delay steroids in adrenal crisis. Never correct hyponatremia rapidly. Never start erythropoietin stimulating agents with iron deficiency, and never forget to check potassium or ECG in AKI, and never ignore a rising creatinine after ACE inhibitors. Always give fluids first and then fixed rate insulin. Watch for potassium. Give hydrocortisone and fluids immediately in adrenal crisis. Correct hyponatremia slowly, which is less than 8 to 10 millimoles per liter in 24 hours. Replace iron first before administering erythropoietin in CKD anemia, and treat hyperkalemia with calcium first to stabilize the myocardium, and then go with further treatment of hyperkalemia. And when there is a rising creatinine after ACE inhibitors, always suspect renal artery stenosis. Some single best answer pearls. When there is in endocrinology, so when there is a low TSH and high T4, it is primary hyperthyroidism. Gland is functioning well and there is negative feedback. Okay, it's seen in Graves' disease, especially if TRAB is positive along with eye signs. In diabetic ketoacidosis, you have to give fixed rate insulin, fluids, fixed rate insulin, monitor potassium. Okay, it can cause hypokalemia, so monitor potassium. In HHS, rehydrate first. In adrenal crisis, give IV hydrocortisone and fluids before you try to establish the diagnosis. In bitemporal hemianopia, go ahead. It is usually because of mass in the pituitary, so go ahead with MRI. When there is prolactinoma, treat it with cabergoline. When there is high calcium and low parathyroid hormone, it is always caused because of malignancy. Treat it with fluids and bisphosphonates. In syndrome of inappropriate secretion of ADH, the patient will show euvolemia with low serum osmolality and high urine osmolality. Treatment is fluid restriction. For pheochromocytoma, remember alpha blockade first before beta blockade to avoid hypertensive crisis. In case of renal, AKI, exclude obstruction, stop nephrotoxins, always monitor potassium. If there is history of drug intake, rash and eosinophils in the stem, it will indicate acute interstitial nephritis. When there is hematuria with upper respiratory tract infection, if it was just within days, it is IgA nephropathy. If it was 2 weeks later, then you should think about post-streptococcal glomerulonephritis. For nephrotic syndrome, always remember there is a risk of VTE or vascular thromboembolic event. So think about renal vein thrombosis as a complication in nephrotic syndrome. In hyperkalemia, give calcium first to stabilize the myocardium, then give insulin and dextrose to cause movement of potassium into the cells. Then we should think about excretion with dialysis or sodium zirconate. AKI after ACE inhibitors, think about renal artery stenosis. Indications for dialysis is AEIOU. Remember the mnemonic. For myxedema, coma and endocrine emergencies, go ahead with hydrocortisone, levothyroxine. With thyroid storm, treat the symptoms with beta blocker. PTU, iodine and steroid can be used to manage storm. For euglycemic diabetic ketoacidosis or SGLT2 inhibitors, always check for ketones. In hypopituitarism, always give steroids before you're starting other hormones. In pituitary apoplexy, give steroids and arrange for urgent MRI to find out what's happening. And for hyponatremia, always correct slowly to avoid demyelination. And in Addison's disease, you can have low sodium, high potassium, and look for pigmentation. For renal essentials, in basement membrane, look for antiglomerular basement membrane or ANCA when you are having simultaneously lung and kidney injury. Okay, like in Goodpasture syndrome, they will give you symptoms of lung injury and kidney injury, and the treatment will be urgent immunosuppression. For peritoneal dialysis, you can have questions based on peritonitis. It will be cloudy fluid. For that, you need to give intraperitoneal antibiotics. In CKD anemia, you should correct iron before giving erythropoietin stimulating agents. For renal tubular acidosis, type 1 will be associated with stones and hyperkalemia will be found in type 4. In type 1 and type 2, it will be hypokalemia. When there is cholesterol emboli, you will get a stem based on post-angiography AKI, lipidoreticularis and eosinophilia. So when it is a contrast nephropathy, stop the nephrotoxic, hold all the nephrotoxins and hydrate the patient well, actually before the procedure and after the procedure to minimize contrast nephropathy. So when there is metabolic acidosis, always check the anion gap. It can be high anion gap metabolic acidosis. The causes are hot piles, methanol, uremia, drugs, paraldehydes, all that can cause high anion gap metabolic acidosis. And it can also be normal anion gap metabolic acidosis when there is hyperalimentation, hyperchloremia, then acetazolamide infusion. All that can cause normal diarrhea. All that can cause normal anion gap metabolic acidosis. Now, this is just to know what happens in Graves' disease. It is a revision of what was already taught before and today when we started the session. So in Graves' disease, high thyroid hormone, high T4, low TSH with eye signs and TRAB. Okay, and the treatment is with carbimazole and beta blocker for symptoms. In adrenal crisis, hypotension, hypoglycemia, low sodium, high potassium with pigmentation, give hydrocortisone and fluids. If you're suspecting syndrome of inappropriate secretion of ADH with euvolemia, low sodium, high urine osmolality, okay, low plasma osmolality, high urine osmolality, then the treatment will be fluid restriction. Now, hypercalcemia of malignancy, calcium is high and PTH is suppressed, you can expect hypercalcemia of malignancy, you treat with aggressive fluids and bisphosphonate. When there is galactorrhea, high prolactin, microadenoma, it is a prolactinoma, you can treat it with cabergoline. In interstitial nephritis, AKI will be there in the presentation along with rash, eosinophils, and a new drug like NSAIDs or PPI. You should recognize it to be interstitial nephritis. And how will you treat it? You need to stop the drug. You can or may not use steroids. Okay, IgA nephropathy is hematuria days after. They will give you a history of 2 to 3 days after upper respiratory tract infection. Synpharyngitis, remember, and the treatment is supportive and controlled BP using ACE inhibitors. In hyperkalemia, if you're finding tall tented T waves and rise in potassium greater than 6.5, go ahead with hyperkalemia emergency management with IV calcium gluconate first, then insulin dextrose infusion along with salbutamol nebulization, and finally you can help excrete the potassium from the body using sodium zirconate or Lokelma, which are potassium binders, and then dialysis if you need further fast action. In renal artery stenosis, the question will show a steep rise in serum creatinine and bruit after initiation of ACE inhibitors. The treatment is to stop ACE inhibitors, image and revascularization where necessary. And then for refractory overload or acidosis or uremia, AEIOU, acidosis, refractory that is electrolytes, refractory hyperkalemia, then overload and uremia, all that indication dialysis, you need to go ahead with urgent hemodialysis for such patients. So the sources that has been used for preparation of this slide, you can see. I wish you all. This brings us to the end of today's revision session. I wish you all the best in your upcoming exams. Trust your practice, trust what you have studied, and go ahead with confidence. Okay. Once again, reminding you for our further programs for PACES. I'm sure all of you, I wish you all success. And once you succeed in your MRCP 2, you can consider practicing or preparation for MRCP PACES with our courses in Study Medic. There we have a 2-day live on-site course and 1-to-1 course as well, like I explained earlier during our presentation. Thank you.